So, very renowned speakers and very important topics as well. So, we are a little bit running short of time, so without wasting much time, let us go directly. And you know that Lakshmi Manchikanti needs no introduction. So, most of us are here just to hear his lectures. Welcome you, sir.
Good morning. Good news, this is my last lectures. Okay, we're going to talk about adhesiolysis in failed back. I really don't want to like the failed back name, but that is the title I was given. So if there are any surgeons, I don't want to offend you. There is failed back with epidural also, failed epidural, failed chiropractic, failed physical therapy, and failed everything. Okay, this doesn't work. Technology in India is so famous across the world, but it doesn't work in India. You go to the airport, you lose your luggage, it takes you 3 hours to get the information. They have to put it in the computer, and then they have to prepare a hard copy. Then they will give you one after you waited 1 hour. So that is my disclaimer again. You have been seeing that few times, so I'm not going to go over this. So we are talking about epidural adhesiolysis. Originally, it started with so-called neuroplasty, and then we thought, well, we are not really doing any neuroplasty, so we are doing adhesiolysis. So I was the one who promoted the word adhesiolysis. Gabor wanted the neuroplasty. Now we are facing a reversal of the situation. Insurance companies are saying adhesiolysis. So are you doing the abdominal adhesiolysis? Or that is such a nonsense, but that is what they are saying. So they started using neuroplasty again. So it can be called epidural lysis of adhesions, epidural adhesiolysis, epidural neurolysis, neuroplasty, hypertonic saline neurolysis, non-endoscopic adhesiolysis, and people call it by the name of Rax, who is the founder of this technology. I don't have enough time to explain how he came across this. He's an innovator, but more like an evolution from a continuous epidural catheter. That is how it happened. So they were giving morphine infusion through a catheter, and it was not effective. It was blocked. So what happened was it kinked. After that, they removed the kink, but nobody watched the patient, and patient died. All the medicine was sitting in the tube. Once the kink was removed, everything went into the spinal canal. That was intraspinal morphine. So he started thinking, how can I prepare a catheter which won't kink? That is what the development led to, and the first article was published about a non-kinking catheter in JAMA. So historically, we started with epidural injections by Sickard, as we were talking about yesterday, in 1901. In 1909, these two groups of doctors, again from France, said that they can cure sciatica just with procaine epidural. After that, first epidurogram came. In 1967, they started using intrathecal cold hypertonic for a different purpose, but it demonstrated the safety, and incidentally, they noted that it was helping their back pain too. After that, they used the hypertonic sodium chloride solution because they thought that it was going to absorb all the water and edema will be released. That is how it was going to help in back pain, because everybody was thinking by this time into the inflammation theory retroactively. In 1980s, as I said, Rax and co-workers published their first article on the catheter, and then they also published the case reports, but nobody was believing this is a controversial procedure from the beginning. After that, we got involved, and I published several articles on that. In 1999, they performed a first randomized double-blind controlled trial. Again, it continued to be controversial. Study was criticized for its deficiencies, limitations, and it came from Dr. Rax. Raj was a co-author. So we did a double-blind randomized controlled trial, and they said this was done by Rax's friend from a small town. So we continued the criticism. We did another double-blind randomized controlled trial in 2012. So now they are saying that they want something by excluding Rax and Manchikanti. So we are trying to do these studies. So they designed a study. They started doing it, like all of you are so excited to get involved in these things. And that study was never finished. It started in 12 centers where I was not involved, but they never were able to finish it. So there are three issues here. One is the lysis of adhesions, target-specific injection of the steroid or any other solution, hypertonic sodium chloride solution. There is a fourth component, hyaluronidase injection, which is even more controversial. Post-lumbar laminectomy syndrome, that is probably the right word, but with all the fusions and disc prosthesis, we can't even call that anymore. So we simply call it post-surgery syndrome. So it encompasses all types of surgical interventions. All surgical interventions can cause epidural fibrosis and also biomechanical instability. Like I was telling yesterday, Feinson said that, but I said Patwardhan said, but in any case, one of the neurosurgeons said that no matter how severe and intractable the pain, it can always be made worse by surgery. You should always remember this and tell the patients when they ask to go for surgery. They will thank you or hate you or whatever happens, but at least you have given the proper information. This is always a possibility when you have the surgery. No surgeon will tell this except Patwardhan, Lawrence, they're all in the same group. The disc treatment originated, as all of you know, with Mixter and Barr performing the first surgical decompression. Until then, they actually thought that it was a tumor which was causing the pain. They didn't realize that it was the disc herniation. Amazingly enough, within 1 year, which included Mixter and another surgeon, this surgeon is from a different area. Mixter was from Harvard, whereas Iyer was from Memphis, Tennessee. They both together postulated that you do not need to have a disc herniation. Disc itself can leak and cause radiculitis. So what we are talking about today, the internal disc disruption and discogenic pain, is nothing new. It was 1934, they talked about the disc herniation and disc decompression. 1 year after that, they came up with the discogenic pain theory, where you do not find any neurological signs, but you do have the radicular pain. This is the concept, radiculopathy, radiculitis, and radicular pain. So after that, Barr reported that a patient may have persistent low back pain, sciatica, or both, in spite of surgical intervention. That is where the post-surgery syndrome started in 1951. The open discectomy does cause loss of structural integrity and changes in the load-bearing capacity, creation of epidural fibrosis, subject of our discussion. Above all, it causes the weakening of the annulus of the disc. So when you are doing percutaneous disc procedures on a patient who already had surgery, it becomes very difficult. So failed back surgery syndrome or post-laminectomy syndrome may result from incorrect diagnosis, unnecessary surgery. These are the things we like to talk about. Inadequate surgery, improper surgery, but it can also result from a well-indicated, a well-performed surgical intervention. Causes of failed back surgery syndrome are epidural fibrosis, arachnoiditis, facet arthropathy. This is one of the most ignored conditions. They say that, well, patient has post-surgery syndrome, nobody wants to look at if their facets are hurting. There is 16% prevalence of facet joint pain in these cases. We have done 2 studies on this. So at least 16% in post-surgery syndrome patients. Instability, that is when they need the fusion, if it is more than grade 1. Spinal stenosis, you need the decompression. And adhesiolysis will help in spinal stenosis also. So patients with post-surgery syndrome with spinal stenosis actually are the best candidates for adhesiolysis. Myofascial syndrome, you can do all types of treatments, including dry needling. Sacroiliac joint arthritis, recurrent disc herniation, you can manage them conservatively or you may need surgery. Complications of fusion and pseudomeningocele, it's not that common, it does happen. But does epidural fibrosis cause pain all the time? It is highly controversial. Many of the physicians believe that it really does not cause, especially the neurosurgeons. You discuss with them. I have been on many forums to get this procedure covered by Medicare and other insurers. You should see the arrogance on the other side when they are talking about it. They say that, no, you can't do the adhesiolysis. One surgeon told me that he has difficulty cutting the scar tissue. How can you do that with a catheter? So it is an inflammatory reaction of the arachnoid. It is a fine, non-vascular and elastic tissue enveloping the central nervous system. There are 3 compartments, dorsal, ventral, and lateral. Ventral and lateral epidural fibrosis is the important one, which is symptomatic. It was rare prior to 1935 because we didn't know that. Chronic spinal meningitis was the reason why they thought adhesions were developed. Peridural fibrosis, but now we also know that there are various conditions which cause nerve root fibrosis apart from epidural fibrosis. Epidural fibrosis extends over the nerve roots, can cause the nerve root fibrosis. So that is the reason some patients, even though you do the epidural adhesiolysis, they do not respond because you are not addressing the nerve root fibrosis. Post-surgical, of course, we know that every time there is small hematoma, and that leads into the epidural fibrosis, infection, and non-surgical causes like annular rupture. The inflammatory process creates the adhesions. These are much easier adhesions, and you can just put a catheter and they go away. Even your flimsy catheter we use in OB and everything else, you can just push them away with those. Inflammatory response and disc herniation. So epidural fibrosis, McCarran, he's also from Texas Tech University, where Gabor Rax practiced in 1989, did this experiment. After that, there are about, if you look at the literature, there are about 200 articles or so showing, but this was the first article where they showed that experimentally. They took the spinal cord and injected either sodium chloride solution or nucleus pulposus. That is how it looks. Sodium chloride solution is pretty nice, whereas nucleus pulposus, it shows significant epidural fibrosis. So epidural fibrosis pain can cause, we all hang our hat on this article, which was published in 1996 in Journal of Neurosurgery. Neurosurgeons don't like this concept, but they did publish this article in their own journal. So what it showed was patients with extensive peridural scarring were 3.2 times more likely to experience recurrent radicular pain. Presence of scar tissue, this is the Kushlik article I was showing if you attended on first day of the conference. Kushlik was the one who described all the pain structures by doing local anesthetic. And what he showed was, am I already done? Oh, okay. He was the one who showed what structures were mostly painful, often painful, all the time painful, and never painful. So the inflamed nerve and the skin were the structures which were always painful. The skin, it is always painful, and inflamed nerve root, and all other ones are lesser painful. So sciatica can only be reproduced by direct pressure or stretch on the inflamed, not non-inflamed nerve root. Inflamed, stretched, or compressed nerve root, that is also Kushlik. Postoperative scar tissue renders the nerve susceptible to injury. This is an extremely important article from Sanger. We quote that all the time. Perineural fibrosis interferes with CSF-mediated nutrition and can render the nerve roots hyperesthetic as well as hypersensitive to compression forces. This is the mechanism of spinal radicular pain and dysfunction. One is the nerve root compression and dysfunction leading to deformation of the nerves, impairment of the blood supply, decrease in nutrient support, intraneural edema, and intraneural fibrosis, vascular compromise, inflammation, biochemical factors, post-lumbar laminectomy syndrome with epidural fibrosis, instability, then spinal stenosis in itself, herniated disc, can cause periradicular fibrosis, that is the nerve root fibrosis, other vascular abnormalities. So adhesiolysis can be performed by different routes, but most common route is the caudal. Interlaminar, there are a lot of issues. It is a difficult entry. And especially in post-surgical patients, you do not want to try interlaminar. It can cause spinal cord trauma if you go above L1. And chance of dural puncture are extremely high. With caudal, easy entry, minimal risk of dural puncture. You can still have dural puncture. Some people have abnormal extension of the dura up to S2, S3. So theoretically, we put the catheter up to S1 generally, but you can rupture if it is long extension. And there is no difficulty in post-surgical patients. It is also accessible with endoscopy if you like to use endoscopic disc decompression, endoscopic adhesiolysis. Transforaminal, it is target specific, but you are going to face the same risks you are facing with other procedure, and it becomes more difficult. And you do reach the ventral epidural space, and it is also limited to lumbar region. Nobody would do this in thoracic or cervical region for that. And you can cause intraneural damage because you are using a catheter and a large needle. And if there is fusion and hardware, it is very, very difficult. Corticosteroids, we know the mode of action, and we know the mode of action of local anesthetics. And there is a lot of evidence that corticosteroids have anti-inflammatory action, same way local anesthetics have anti-inflammatory action and multitude of other actions. Hypertonic sodium chloride solution is the one we haven't discussed and which is special to this procedure. It reduces the edema and it causes local anesthetic effect and also promotes the lysis. Now I heard that you can't get 6% hypertonic sodium chloride solution here, so you guys use 3%. Now 3% is also effective, but less effective than 6%. So what are the indications? History of chronic low back pain. There should be a minimum pain of 6 out of 10. If you are using VAS, it's a great tool, but do you know what a VAS is? With the education level in India, I would be really surprised if people do understand what VAS is, and physicians have that much of patience to measure VAS. I heard the lectures, VAS. Numeric rating pain scale will be much, much easier to apply, and both are equally reliable. VAS is you take a blank paper, you all know that, right? You take a blank paper, you put 2 points where the pain is, the worst pain and no pain. So then you measure it. The patient doesn't have an idea what he is doing, so it may give you right information. But in a numeric rating scale, you can ask the patient question on scale of 1 to 10, where is your pain? So it is 11-item series. You can use 1 to 100, then it becomes 101. But it is much easier to get a numeric rating scale for practical purposes. So you also need to rule out the facet joint pain. If patient has facet joint pain, adhesiolysis is not going to work. And patient should have failed to respond to conservative treatment, including fluoroscopically directed epidural injections. There are a lot of contraindications. You all know those. So there are controversies in reference to, do you want to do this on a 1-day procedure, 2-day procedure, or 3-day procedure? When Gabor started, it was a 3-day procedure. So I tried to change it to a 2-day procedure because I didn't want patients to coming back 3 days. What he was doing was admitting the patients to the hospital. In those days, they paid a lot of money. He was generating a lot of money for the hospital. They loved it. But it was, in private practice, it was difficult. So I tried to do it 2 days, and we looked at the results. There was no difference between 2 days, 3 days. So I said, wow, okay, let us try 1 day. So we just tried 1 day and did it, and there was no difference. And we have issues related to type and dose of local anesthetic and steroid. Hyaluronidase, do you want to or do not want to? Hypertonic sodium chloride solution, do you want to use it or not? And do you want to infuse it or give it as a bolus? The bolus was my idea. Gabor's idea was infusion. He wanted you to buy a machine and infuse it over a period of 15 minutes or so. How many days? So this is the technique Gabor Rax has described, and that is what they follow. This is the old technique. Only the difference now is that they use ropivacaine instead of bupivacaine. This is the technique I described, modified from them. Actually, I even modified a catheter to make it cheaper. In the United States, his catheter costs $94. My catheter costs only $42. So we modified it and made it smaller and more stiffer. In this technique, what we do is, after you do the adhesiolysis, you position it and you confirm that you did do the adhesiolysis. And after that, I inject 5 ml of 2% lidocaine, then transfer the patient to the recovery room, watch them for 10 to 15 minutes, minimum of 10 minutes. Then we inject 6 ml of 10% sodium chloride solution in 2 divided doses. After that, we inject either depomedrol or celestone sodium if we are going to use the steroid. Then inject 1 ml of normal saline to flush the catheter, and then remove the catheter, send the patient home. So procedurally, this is how we do it. You do the procedure by an AP view or lateral view, place the catheter, identify the scar tissue. You can see on the right side there is filling defect. And you place the catheter, do the adhesiolysis, and then inject the contrast again. So generally, I end up injecting only 10 cc, 5 cc initially, 5 cc later, majority of the cases. Sometimes it takes more, and you can see that that is a beautiful picture. Of course, you show only beautiful pictures in the lectures. So you see that there is filling of the nerve roots, and there is also filling of the epidural space. Now, catheter is lateral, okay? Now, Gabor wants that catheter has to be ventral. So is the catheter ventral in the lateral view? No, it is not ventral. So theoretically, it should be ventral because it is filling the nerve roots. So these theories always don't work. That is the point. If you are satisfied in AP view, if you can get a nerve root filling, don't bother about ventral filling, whether it is irrelevant. It is going to work. This is another patient who had a $60,000 disc replacement surgery and a whole lot worse than ever before. So we did the same procedure here, and again, you see good nerve root filling after the decompression. But now look at this. This catheter is ventral. And you can see the ventral filling pattern on the lateral view also. Now, if you want to go further, the endoscopy, you were talking about the balloon stuff. So this is the same philosophy. It is a thicker catheter, a bigger catheter, so you can go ahead and do adhesiolysis much better fashion. That is the only, we compared, I did studies comparing endoscopy and adhesiolysis. That was the conclusion. Why does it work better than this? There are a lot of complications, technical and related to the drug administration. As I said, there are a total of 4 randomized controlled trials, but my first randomized controlled trial was not very well designed, so I don't even count that as. I was just learning how to do the randomized controlled trials. There are numerous retrospective trials and clinical reports. Now, we are looking at only post-surgery syndrome. There are lots of other studies related to spinal stenosis and also with no surgical intervention in the patient and no spinal stenosis, just disc herniation. So Gabor Rax and Hevner, God bless, both of them are gone now, Hevner and Raj. They included 83 patients, divided them into 4 groups. So sample size became a questionable issue. Only 59 of them completed the study, that is 71%. Do you remember how when you are assessing the quality of a manuscript, you need to look at how many patients were withdrawn at the end of 1 year? So excluded patients or withdrawn were 24, that is 29%. That reduces the quality of the manuscript, the quality of the study. If it is 2-year follow-up, it can be 30%, but at 1 year, it has to be 20% according to Cochrane criteria and our criteria too. So what was their conclusion? This was a 3-day procedure. They did only 1 time, monitored them for 12 months. But they did do the procedures if they needed it after 70 days. So again, it is somewhat deceptive that they are saying only 1 procedure, but many patients had more than 1 procedure. It was beneficial in 49% of the patients at 12 months. Again, it falls just slightly below the 50% threshold to be effective. But look at the results. What is the difference? Did the patients do much better with sodium chloride solution or high hyaluronidase or 10% sodium chloride solution and high hyaluronidase? It really was not significant. There was no significant difference. Even the patients who just received sodium chloride solution, of course they did receive the steroid, did pretty much the same as the patients receiving 10% sodium chloride solution and high hyaluronidase. So what does that tell us? Here, this study was criticized like hell. There was no control group. What is your theory? What are you telling us? What the study tells is that no matter what you do afterwards, it's the adhesiolysis which is effective. So I'm doing another study. I don't have the results yet, but we are trying to look at the same way. Is there any role for even for steroids? In my study, I'm also doing 1 patient, one procedure without steroids. So this is the study we did. We did them into 3 groups: no adhesiolysis, adhesiolysis, and adhesiolysis. In this thing, we used hypertonic sodium chloride solution in one group, and we did not use hypertonic sodium chloride solution in another group. And there was a control group that was just a caudal. So what we did was we just put the catheter up to S2 or S3 and injected the medication. Essentially, it is a glorified caudal. But some people did respond to that too. We don't know why, but that actually gives you a credibility that at least there was a placebo effect. Otherwise, they will criticize you that there was no placebo effect, your study was not valid. So these were our results in this. So in the control group where we did the caudal, these patients already failed caudal before, so you expect that not to be very helpful. It helped somewhat. Whereas group 2, no hypertonic sodium chloride solution, they did pretty much the same as patients with hypertonic sodium chloride solution. Do we still need to use the hypertonic sodium chloride solution? I'm still using it, but we have to look further into it. That's why I'm saying if you have 3%, that's okay, you can use it. Outcome measurements on oswestry were also pretty similar. These are the final results, more than 50% relief.
Really short time.
I'm done. Okay, this is my next study, control group caudal epidural injections, and this is a much larger study, 60 patients in each group. We followed them for 2 years. Overall, there is level 2 evidence. You can say that because these are controlled trials, it is level 1 evidence, but essentially it is not level 1. It is level 2 evidence when you really look at it. Thank you.